Hello friends, today we are going to discuss about diagnosis in psychiatry. I am Dr. Suresh Padadmat, Professor of Psychiatry working at NIMANS, Bangalore. In this video, I'll be discussing about what is diagnosis, what is the utility of diagnosis, types of diagnosis which the doctor makes, and how to make diagnosis, what is the role of clinical investigations, role of psychological assessment in psychiatric diagnosis, and also the controversies regarding psychiatric diagnosis. Let's define diagnosis. Diagnosis is a process of identifying a disease, condition, or an injury from its signs and symptoms. A health history, physical examination, lab tests such as blood test, imaging, CT scan, MRI, biopsies may be used to make diagnosis. Diagnosis classifies people who are healthy and who are not healthy, that is, who are having illness. Diagnosis provides the clinician with the means to organize, interpret range of information, signs and symptoms, and also whether to administer what type of treatment and prognostication. Historically, the diagnosis was regarded as the primary guide to treatment and prognosis, and it is still considered to be the core component of clinical practice. Let's understand the utility of diagnosis. First and the foremost, the diagnosis is a process of investigation. Whether the person is suffering from an illness, what type of illness, how severe, what is the prognosis. Here, you also decide what type of investigation to be chosen. Communicating about the illness. You need to communicate to your team members. It may be nurse, maybe your fellow colleague, physician. You have to communicate to him that this person has these signs and symptoms and I am thinking of this diagnosis. Making a treatment guidelines. At the same time, following the treatment guidelines, updating so that the standard of treatment is similar across the country, if possible across the globe. Further, the diagnosis also is essential to provide social welfare benefits. It may be medical leave, disability benefits, paid leave, and various other benefits which can be considered. For the purpose of research, if you want to do a study on COVID, that means COVID is a diagnosis which you are well known about it. So, for the research purpose, what type of medication to be given, what is this illness, what is the course and prognosis, when does this illness, how many of them people become completely all right. So, for that purpose is also very essential. It is also considered as prognosis. Planning for policy. Imagine if you are a policymaker sitting as an administrator in a hospital, maybe at the state level or at the national level. You need to know what is the prevalence of illness in your area or the jurisdiction so that you can plan the services. Of course, for the finally, the legal purposes, and especially in psychiatry, we deal with the abnormal behavior of a person. And if there is any conflict with law, then of course, the diagnosis also play a crucial role. Further, the diagnosis, as I mentioned, it classifies people into a person who is having an illness or not having an illness. That means it is a categorical in nature. That means whether you have got it or you do not have it. Diagnosis also further says why you got it. That is the question majority of the population wants to know. Many a time the physician may not be able to know why a person has got an illness. For example, if a person has diabetes, the physician is able to tell, yes, he has a diabetes, but he may not be able to completely answer why he has got the diabetes and other SIBs of that patient do not have got the illness. So, diagnosis is usually considered as a categorical, but unfortunately, it is not categorical. It is a spectrum. It is a dimension. For example, I would like to talk to you about hypertension. You may say 120 by 80 millimeter of Hg, that is systolic and diastolic, is considered as hypertension. If the person scores 122, should it be considered as an hypertensive? Suppose if he is stressed out, suppose he is climbed three-storied building to reach the physician office. So there are various other factors also play a role. It is not only the disease factor, it is the biological, it is also the genetic makeup, social, environmental, all these also play a role in assessing the diagnosis. Not only that, we have made certain categorical classification. To this level, we consider it as an illness, and above this, we do not consider, or below this. That means there is a cutoff we have been kept. This is for our understanding. Illness is not like that. Illness is a continuous process from zero to infinity. But our whatever we have understood is the understanding of the science today. It may change tomorrow. The science is constantly evolving. Similarly, the illness are also evolving based upon the various environmental factors and also what the food we take. Let's understand the classification of diagnosis. Diagnosis can be classified into various types. First and the foremost is anatomical diagnosis, based on the structure where the illness has occurred. On that, you can consider it as anatomical diagnosis. The best example is pulmonary tuberculosis. If it occurs in the lungs, if it is in the intestine, we consider it as tuberculosis of the intestine. Similarly, physiology, how the body works, based upon that, sometimes we make diagnosis. Pathology, based upon the pathological slides, what we see, on that also we consider to make diagnosis. Etiological, based upon the cause, we consider and make diagnosis. Radiological diagnosis or a lab diagnosis. The patient may not have any symptoms, but on radiology or on CT scan or MRI, he may have certain disease. So it may be considered as a radiological diagnosis or maybe lab diagnosis. Genetic analysis can give genetic diagnosis. And finally, the commonest which occurs in the day-to-day outpatient basis is clinical diagnosis, that is based upon the signs and symptoms. Invariably, a good physician knows to treat the patient as a holistic, not the investigation. Many a time when the investigations are reported, invariably they will write, please correlate with the clinical signs and symptoms. That means the signs and symptoms play a very important role. Many a time the lab diagnosis may be abnormal, but the patient may be completely normal. Hence, we need to be very careful to how do you interpret the signs and symptoms. Now, further, the classification of diagnosis, especially in psychiatry, falls into other certain categories. Like if a person is admitted for evaluation, evaluation can be ordered by the court of law. Hence, in such a situation, you may consider it as not a diagnosis or under evaluation. Provisional diagnosis. That means you have got certain information, not a comprehensive, complete information to make a diagnosis. You will keep it as provisional. That means it's not the final diagnosis. Differential diagnosis. That means you are considering the person is having either 2 or 3 various other illness, or the possibility of having maybe 1 or 2 more illness, or it may be possible that he may have this or that illness. That means that is a differential diagnosis you will keep. Confirmatory diagnosis. Once you have got all the information and you are clear about the diagnosis, we consider it as confirmatory diagnosis. Dual diagnosis, having 2 illnesses. Comorbid diagnosis, it may be many diagnoses may be there in a single person. For example, a patient with OCD may have depression, may also have tic disorder. Over a period of time, he may develop psychosis. That means he has multiple diagnoses. Retrospective diagnosis. Here, the diagnosis is made based upon the information in the past. If a person had illness 2 years back, but currently he is completely normal, but for the purpose of legal issues, the court may ask you to interpret, but you have to be very careful. You are collecting the information and making interpretation based upon the history. So that is a retrospective diagnosis. But however, as a clinician, you will be treating a person based upon the primary diagnosis. What is primary diagnosis? The reason for signs and symptoms which is bothering the patient, which made him to do consultation today. That is the primary diagnosis. An example I will give you. A patient has alcohol use since 20 years. He has not come for treatment for alcohol use. He has come for headache. Now the primary diagnosis is related to headache. It may be migraine. But you also need to make a secondary diagnosis. Secondary diagnosis is alcohol use. So you need to know what is the primary diagnosis, that is the reason for consultation at this point of time, secondary diagnosis or other diagnosis which also may be contributing for the poor outcome of the present illness. The next is diagnosis by exclusion. The best example is Alzheimer's dementia. This diagnosis is made based upon the exclusion of other illnesses. Self-diagnosis. This is the commonest nowadays. Patient misinterpret the signs and symptoms in their body, and they also go online, read something, and they make their self-diagnosis. Remote diagnosis. The remote diagnosis is based on telemedicine. Here, a patient is sitting in one corner of the world and the specialist is maybe in the other part of the world, and he is making a diagnosis based upon using telemedicine services or technology. It may be considered as remote diagnosis. Now, considering the ICD-11, International Classification of Disease 11, there are other core specifiers have been made. They are like such as illness is in remission. An example is schizophrenia in remission. Or else the patient is having continuous illness, chronic schizophrenia. Episodic schizophrenia, that is course specifier. Treatment responder, based upon whether the patient is resistant to treatment or is refractory. Any kind of approved medicine is not working, and also those medicines which are in research also is not helping. Sometimes we may consider that as refractory illness. And finally, severity specifier, mild, moderate, severe. Based upon this also the diagnosis is considered. However, in DSM-4, which I liked the most, had something called as 5-axial diagnosis, that is multi-axial diagnosis. Multi-axial diagnosis gives you a complete, comprehensive, holistic picture of a patient. It has 5 different axes. Axis 1 talks about mental illness or psychiatric illness along with substance use such as alcohol use or drug abuse. Axis 2 talks about personality issues and also intellectual disability, that is mental retardation. Axis 3 will be looking into general medical condition in the same person. Axis 4 is looking for psychological and environmental problems. The Axis 5 talks about global assessment of functioning. That means if a patient reports to you, you will make diagnosis in each of the axes looking for anything which is contributing for the patient's disability or worsening of symptoms or improvement in the symptoms. Now let's move into the role of investigation, especially in psychiatry. Role of investigation in psychiatry is very minimal. Here, the investigations are used to rule out other causes of illness. It may be neurological causes, neurosurgical causes. Hence, in psychiatry, the diagnosis is completely based upon clinical examination, interpretation of signs and symptoms. Although there has been tremendous of research which is occurring in medical field, especially in radiological, genetical analysis, and various EEG, and also various biomarkers have been studied. But however, till date, there is no single lab diagnosis test which can diagnose psychiatric illness positively. No urine examination, no imaging, and also any EEG studies can positively diagnose psychiatric illness. And please remember this, psychiatric illness are diagnosed by interpretation of signs and symptoms. And the reason for using investigation, as I mentioned, to rule out other condition, such as we use EEG to know whether there is any seizures, we use imaging to know whether the person has any neurological illness or neurosurgical illness. Autoantibodies like limbic encephalitis also can mimic psychiatric illness. Psychiatric diagnosis is basically by clinical examination, interpretation of signs and symptoms across the globe, my dear friends. Now let's understand the psychiatric diagnosis. Here, psychiatric diagnosis is made by interpreting signs and symptoms. The presence of group of symptoms or grouping of symptoms are seen, and those are analyzed by clinical examination and grouped and considered as an illness. For example, schizophrenia. Let's understand disease. Disease can be defined as an health condition that has clearly defined reason behind it. That means there is an etiology behind that. And if you look at the WHO's diagnosis of health, which clearly says it is not just a merely absence of illness, It is a complete physical, mental, and social well being. Here, to develop an illness, the person should have physical illness, physical component, mental component, and a social component of being dysfunctional in the society. But then, what is the syndrome? Syndrome is a Greek word in which it is considered as running together. That means group of symptoms go together wherever they are manifested, and there may be no identifiable cause. But let's understand what is the difference between illness, wellness, maybe even the disorder and syndrome. First one is disease may be considered as a group of a population. There are ill people, there are well people, there are who are distressed. Distress means they're in the borderline of developing mental illness. Now, what is syndrome? Here, the group of symptoms are present in certain group of people, and here that is a syndrome can be considered. But again, the diagnosis cannot be made just based upon some identifiable causes not known here. What is illness? In illness, there is a symptoms are present, and at the same time, biological cause is known, and there is a change in the anatomical structures when you do certain investigation. Now let's consider as what is disorder. Like for example, personality disorder. Here, there is a disruption of the regular functioning of the body, or else in the society, or else maybe in various other system. That is considered as disorder. So you need to know the difference between disease, disorder, and syndrome, my dear friends. Across the world, there are two classificatory systems for diagnosis. One is ICD, that is International Classification of Disease by World Health Organization. Another one is Diagnostic Statistical Manual of Mental Disorder, that is DSM-5 by American Psychiatric Association. So both are considered to be the contemporary diagnostic category system at present. Let's understand how we make psychiatric diagnosis. Psychiatric diagnosis is made by clinical examination, interpretation of signs and symptoms. As I mentioned, you define unhealth by absence of illness, not just an absence of illness. There should be disruption in physical, mental, and social well-being. That means if there is a disruption, then it will be considered as an illness. Otherwise, health is complete physical, mental, and social well-being. And if you look at the assessment to have a physical illness, you will do respiratory system analysis, per abdomen, CVS, and CNS examination, as you know if you have learnt in MBBS. But in psychiatric, how do you do analysis? Here, you will do the analysis of the cognition. You will do the analysis of the feelings and the behavior of the patient. Let's understand what is cognition. All forms of knowing and awareness, such as perceiving, conceiving, remembering, reasoning, judging, imaging, and imagining, and problem solving. Here, the process of knowing, including attending, remembering, and reasoning, is considered as cognition. Cognition is more of thought process and solving the problem in a concrete manner. Feeling what you feel, that is the feel. Whether there is abnormality in feeling, like depression, behavior, abnormal behavior. So these are the three important components which will be analyzed when you are analyzing a person. Let's go into the clinical examination. A good clinical history. How to do that? You need to talk to the patient at the same time with the collateral informants. It may be family members, spouse, friends, colleagues, maybe society members, neighbors, and also other collateral information will give you a good clinical source of information. Collateral information also is very essential, especially in legal cases. And you need to know to rule out organic conditions, that is neurological and neurosurgical conditions. In very simple words, if a patient does not have bowel and bladder incontinence, if there is no disorientation, there is no focal neurological deficits, invariably you can consider them as psychiatric diagnosis. But don't go by my word. You need to sit with the patient and the family members, take a good history, and then you have to need to take a decision whether what type of investigation you're going to carry out. There is a thin line between normalcy and abnormalcy that you need to understand. That means if a person has irritability, When do you call the person as mania, or else whether it's a normal irritability? Both you and me can become irritable if something goes wrong. Can we consider it as a mania? Or else depression. Everyone on in this earth would have felt sadness. When do we call depression? It is based upon the quality and the quantity of the symptoms and duration of the symptoms. That means for every symptom which the patient presents to you in psychiatry, you need to quantify, qualify, know the duration and how much the dysfunction the patient is having because of the symptoms. One of the best way to know is the yardstick is whether is occupational functioning, whether it is social functioning, academic functioning, being in a family member, whether he's able to earn his livelihood, whether he's able to enjoy his life, whether he's able to contribute in the society is the best yardstick to know whether the patient has dysfunction or not. Another example I can give you is headache. Everyone on this earth would have got headaches some point of time in life. When do we consider treating them aggressively and investigating them, or else to consider whether he has a migraine? It is based upon the quality of the symptoms, quantity of the symptoms, severity of the symptoms, duration of the symptoms, and how much the symptoms comes in the way of functioning in the society. Now, the symptoms also need to be understood from biopsychosocial approach. Here, there is something called as 4P models. 4P model is predisposing model, precipitating, perpetuating, and protective. What is predisposing? Predisposing is biological constituents, that is genetics. That means nothing comes out of zero. There should be a predisposing condition such as genetic vulnerability which will push a person to develop psychosis or a depression. That is predisposing. Or else maybe psychological trauma, social violence at home, all those can be considered as a predisposing factors. What is precipitating factors? Here, the recent event, which is a stressful event, which precipitated the illness. It may be iatrogenic, it may be a trauma, maybe accident, exam stress, maybe substance use. All these can be a precipitating factor. What is perpetuating factor? The factors which enable the patient to continue to be ill or continue to have sick role will be considered as perpetuating factors. And finally, the protective factors. Here, a good family support, good economical support, availability of medication, and also good response to treatment will be considered as a protective factors. All these 4P models are very essential to know about a diagnosis, prognosis of the diagnosis, and outcome of the diagnosis. Let's understand how to do mental status examination and cognitive function and what role they do. Here, in mental status examination, you will be looking into the behavior first. In the behavior, general appearance of behavior, here the person, how does he come to your clinical examination room, how is he dressed, how is he behaving with you, whether he has mannerism, whether he has restlessness, whether he is able to sit in one place. That means complete general appearance, behavior, and motor activity will be captured. Further, you'll be looking into the cognition. How to assess cognition? Cognition cannot be seen. The patient has to express through by his speech. Now you will be looking into the speech. What is the speech? Whether it is coherent, irrelevant, tone, tempo will be commented. After that, you will enter directly into the thought process. You will comment whether his thoughts, as how it is formed, whether they are flowing continuously or not, whether there is any delusions, whether there are any illusions, whether there are any preoccupations, or else even suicidal ideas will be considered. And now you will move into the mood, that is emotions, whether there is any emotional abnormality is there, maybe frequency or infrequent, all those will be captured. Finally, the perception will be considered, that is hallucinations, illusions will be captured. Further, the cognitive functions also will be looked in from orientation, attention and concentration, intelligence, judgment, insight, and this mental status examination One time may be of lesser value. If you do multiple times over a period of 1 to 2 months, you will get a good source of information and your diagnosis becomes highly credible. That means serial mental status examination is required whenever you are doing forensic examination. Hence, whenever there is a court orders for the opinion, request the court for admission over a period of 1 to 2 weeks and if possible 4 weeks, because you have to do serial mental status examination to know the pattern, to know the quantifying the symptoms, qualifying the symptoms, to know the severity of the symptoms, how much the symptom is coming in his way of functioning. Moving to the ward observation. Here, you need to do serial ward observation because the patient may report he is depressed, but otherwise his behavior do not say that he is depressed. Hence, look into his sleep, bowel bladder activity, personal hygiene, whether he takes bath or not, how he is maintaining himself inside the ward. Behavioral excess, that means whether the person is irritable, violent, very friendly, whether he has hallucinatory behavior, whether he has hoarding behavior, whether he has disorganized behavior, or any unacceptable behavior in the society that can be seen in the ward to be noticed. Behavioral deficit, whether the patient is not meeting anybody, sitting quietly in the room, does not interact with anybody, does not interact with the staff, and he does not have any motivation to do anything, and also takes very less food. All those can be considered as a behavioral deficit. Social behavior, how is his behavior with the staff, with the other inmates, with the family members and friends. And also you can now consider how he is interacting with others on social media. Request for his needs and contradictory behavior, whether if the patient says I am sad but he is actually having a good fun in the ward, that means any contradictory behavior need to be noted. Hence a serial ward observation gives you a very rich source of information for a diagnosis. Moving to the structured assessment. Till now we were doing clinical assessment. Why do we require structured assessment? Structured assessment is required so that if you do a structured assessment either by me by using certain tool, it may be YBox, SKID, BDI, MMSE, the report and the result should be same across all the examiners in a single patient. So structured assessment becomes very essential for research purpose, especially for clinical drug trial. Also to compare studies between various countries, structured assessment becomes an important tool. Now move to the semi-structured assessment. In semi-structured assessment, you will be given ample of opportunity to ask your own questions. For example, MINI, that is Mini International Neuropsychiatric Interview, schedule for clinical assessment in neuropsychiatry scan by WHO, fitness to job trial, capacity to assessment, and also competency to make a valid will. So here there is a guideline or a schedule, but however, the clinician can ask his own questions based upon the role of a culture, based upon the patient's language. He will give certain questions and interpret that. Here, there will be some amount of maybe independence given to the clinician. Moving to finally, the role of psychological assessment. The role of psychological assessment, although has been considered very heavy in the past, but currently the role of psychological tests, especially in diagnosis, is very limited. It is limited especially to know the severity of intellectual disability. That means whether to know between whether the person has mild mental retardation, moderate mental retardation, severe or profound. Although the good clinician be able to make the differentiation by a good clinical investigations, by asking a good history and taking collateral information. But however, for the purpose of law, sometimes you may have to do IQ assessment. Next, the personality assessment, diagnostic psychometry, projective test, draw a man test, or a neuropsychiatric assessment. None of them have been included, especially with regard to diagnosis, either in ICD-11 or in DSM-5. That means psychological assessments play a role in giving a direction, but not in the diagnosis of a patient. It may help in understanding the patient. It may help you in planning the management. However, for the purpose of diagnosis, there is a limited role in psychological assessment, especially for all psychiatric disorders. Actually, the intellectual disability and SLD is the only place where it plays some role in assessment. Now let's understand the pros and cons of psychiatric diagnosis. What are the positive aspects of psychiatric diagnosis by clinical examination? It deals the human directly. It is, you are talking to the patient directly. You are able to ask the question, know the client's signs and symptoms. That means you have not reduced the patient into a lab investigation and then knowing the diagnosis and then talking to the patient. Nowadays, if you go to any of the corporate hospitals, they will put you on a battery of lab investigation and finally the doctor sees. But in psychiatry, you will be seen by the psychiatrist first, and he will decide whether to rule out any other neurological or neurosurgical condition, and then only the investigation is ordered. Invariably, the investigation done by psychiatrist will be very minimal. Hence, you deal with the patient as a completely, and it is based upon collateral information provided by the patient and patient family members, and also you make all efforts to understand the patient. Why he is feeling, what is his cognition, how is his behavior, under what circumstances is occurring, and you will look into biological, social, and other models will be considered here to know the diagnosis. It is not based on investigation, and we don't treat the investigation even in physical condition. What are the cons? That means here, many of the people, including general public, believe psychiatry is not based on sound scientific temperament. Like diabetes, you do glucose test and say yes, the glucose level is very high, or else you check the BP and say yes, the BP is very high by using some instrument. That means here in psychiatry you do not have that objective assessment. That is the biggest drawback of psychiatry. But still positively means the objectively we are assessing the patient, and here there is no objectivity is the biggest threat to the psychiatric diagnostic credibility. But however, structured assessment has brought that objectivity now, and you can consider it as there is no reliability. But again, the structured instruments, structured training programs have brought a lot of reliability with regard to psychiatric diagnosis. Many a time, general public, anti-psychiatry movement people say that psychiatric is pathologizing the human suffering or human experiences. Patient or a people feel sad. Why do you want to call them as depressed? And why do you want to give treatment to them? And why you want to subject them and consider it as a mentally ill, stigmatize them, discriminate them, and also many a time they will not be given any kind of job. So why to put them into a hardship making a psychiatric diagnosis? At the same time, if you don't make psychiatric diagnosis, the worldwide they may not be able to get any kind of help with regard to maybe health insurance, maybe social welfare benefits, maybe if the person is in conflict with law, they will be treated as a normal person. Hence, psychiatric diagnosis has its own positive charm and also the negative, maybe considering that may not be scientific or charming. At this point of time, psychiatry, that means research into brain, is slowly evolving. It takes time, and at the same time, it's a wonderful opportunity to know the brain's mystery, and that is psychiatry, my dear friends. Now let's understand what is the fact. The fact, even medical illness is irreducible element of a subjective play of a role. That means, why should be hypertension 120 by 80? Why not 130 by 70? That means it is our own cutoff. There is also some amount of subjectivity again in glucose level in the body, sugar level in the body. Why should be the same for across same person across the world or to the population of human being? Again, we have made a subjective decision. This is a cutoff to categorically to define. Otherwise, there is nothing called as cutoff. Here it is diabetes, on the other day it is not diabetes. It is not like that. At the same time, we need to come out of this phenomena of thinking categorically. It is a dimensional aspect. A spectrum involvement is there. Psychiatry has moved from the precox feeling Earlier, the patient used to say his symptoms, and the physician used to feel, yes, there is something odd about this patient. That precox feeling is there, then they used to make schizophrenia. Now it has moved from that subjective experience through a diagnostic criteria symptoms. We are able to make a objective diagnosis. And also that is the part of being art in medical practice or medical science. That means there is a signs and symptoms. You are using scientific methods to interpret the symptoms, but how to elicit those symptoms, the art of touching the human being by being very gentle and having empathy and humanity plays a role here. That is the reason medicine is both an art and a science. That means they are interdependent and also inseparable, just like two sides of a coin. So medical practice is both practicing science and also an art. You should be an artist to interact with the patient, elicit symptoms, and also heal the patients. Psychiatric diagnosis is always considered as single and constant. That is a myth. The truth is, psychiatric illness comes in multiple diagnoses. Comorbidity is the rule many a time. Dynamic, it is not constant. The patient may have one illness today. By the next year, he may develop another illness. The patient would have had depression this year, may have mania in the coming years, and also he may develop schizophrenia. There is no hard and fast rule. A patient who has bipolar illness should not get schizophrenia. He may also get schizophrenia. Similar to physical illness, a patient has developed tuberculosis this year. Next year, he may develop enteric fever. That means there is nothing called as constant in psychiatry. Psychiatric illness is caused by psychological causes only. Sorry to say that. It's a myth. The truth is, it is a combination of factors. Biological factors, social factors, environmental factors, and of course, predisposing factors, what she had mentioned earlier, and precipitating factors. Psychiatric diagnosis occurs because of poor parenting or childhood sexual abuse. This is, to some extent, may be true, but it is very, very reductionistic approach. It is a combination of factors. Combination of factors which I had mentioned clearly: genetic vulnerability, environment, trauma, parenting. All the combination of factors plays a role in the development of psychiatric illness. To conclude, my dear friends, psychiatric diagnosis is through clinical examination, serial mental status examination, and also serial ward observation will give you accurate diagnosis. Hence, many a time, whenever there is a legal requirement of diagnosis and you need to give opinion in the court of law, it is prudent to ask for admission and then serial observation and serial MSc. Please remember, the role of investigation is very minimal in psychiatry, and you need to use these investigation to rule out organic conditions only. To have this psychiatric diagnosis, we need to follow either the ICD-11 or DSM-5 so that we are considered to be more structured, so that we can overcome this criticism of being very subjective. Since there are very clear-cut guidelines are there, diagnostic criteria are there, use structured assessment for making diagnosis. Of course, semi-structured assessment is required in very complex cases. Role of psychological assessment in psychiatric diagnosis is very limited. Thank you very much for giving your valuable time. Stay safe.